Okay. Good morning, one and all. I thank you for inviting me to the talk on perspective towards disability from dysfunction to function. Before we delve further into the topic, I would say that this talk consists of four subtopics. And before we go exploring how physiotherapy has influenced life of people with disability, I would like to emphasize that there is absence of metrics or there is no single metric with which we can infer how and where physiotherapy has put India on global health map in shaping dysfunction to function. Before we discuss how physiotherapists can find metrics to highlight their increasing role in the field of disability and rehabilitation, we need to discuss how the perspective about disability has changed and how the change in vision of disability has enabled physiotherapists to work in field of disability. What we see now, for example, the increasing number of medals in the Paralympics is one of the reflection or indicators of rising role of physiotherapy in training disabled athletes alongside with coaches. This is just one visible role, while other roles have not been so visible. The other visible role we could talk about is role of physiotherapy in COVID era. So these are two of the many indicators of what physiotherapy in India has done. So before we embark on this talk, I have two pertinent questions. How the perspective in understanding of disability has changed over years and how we have shaped dysfunction into function. Now, how the perspective has changed over years, this is pertinent so as to create an environment of inclusion of people with disability into the planning services and setting a stage to make world aware of people with disability and the rights they have. This has been possible by having conventions, creating frameworks, creating an environment, and creating precursors. Before conventions, also, the people with disability existed, but their rights were never discussed. Their rights weren't similar to other citizens of the country with no specific framework to acknowledge how they would be enabled to enjoy the rights accorded by the Constitution. The convention and frameworks at international level have given impetus. So this helps us in understanding how the government has worked from bottom to top and top to bottom approach through a signatory to United Nations. And with the input of these frameworks and conventions, we have been able to create awareness about people with disability and amalgamate certain frameworks in our constitution. If you look at the timelines of convention, the situation will become clearer. Before these conventions, the arena was disorganized, discriminative, and there was sign of stigma. Disability status was not canvassed in India's census from 1941 to 1971, and disability has been included from 1981 onwards, census of 1981 onwards, and there was only documentation of three types of disability. Then we have progressed from 1981 with the International Year of Disabled People to World Program of Action concerning disabled persons in 1982. And United Nations have declared Decade of Disabled Persons from 1983 to 1992. And there is an extension of this Decade of Disabled Person regionally. So we have Asia Pacific Decade of Disabled Persons from 93 to 2002. So between 93 and 2002, we have Standard Rules of Opportunities, which was given by WHO, to which India is signatory. Then we have this introduction of Bivako Millennium Framework. There were priorities, Bivako Millennium Framework +5 for action 2002, and they have in depth spoken about people with disability and the rights they have. In 2006, we have this Convention on the Rights of People with Disability 2006, and this ushers a new era of People with Disability Act 2016 for India. But I would like to tell before 2002 Bivako Millennium Framework, um, only one question was added to the census in 2001, and that was also added at the last minute. So 2006 convention is a landmark, and we have ushered into the era of Disability Act of 2016. Now, how we have shaped dysfunction into function? We have precursors, we have laws, we have policy, we have healthcare, we have introduced technology in healthcare. Now, if we will be talking about them one by one, let's talk about the laws. Within these decade of disabled people that is extended from 93 and 2002 onwards, and before that we have had Mental Health Act 1987, and then we have RCI Act 1992, then we have Equal Opportunity Act and Protection of Rights and Full Participation Act 1995, and then we have National Trust Act 1999. So all these things happened within the decade of disabled people from 1983 to 1992, and from 2002 onwards we have been working on rights of people with disability, and finally in 2016 we have this the law Rights of People with Disability Act. Now, if you look at the policy document on Divyangjans released in 2021, the terminologies like participation, environmental barriers, moving from social model to from medical model to social model, and inclusion of terminologies like adoption of ICF in disability surveys. All these things have happened right now in 2021. So I must say the government machinery has caught up very fast. And we have provisions in the Constitution, that is Article 41 and Article 46 of the Indian Constitution, where they have spoken about people with disability and handicap along with the weaker sections of the society. So there are provisions in Article 41 which talks about provision of right to work and education and public assistance in cases of unemployment, old age, sickness, and disablement. Then you have Article 46, which lays down special care to the education and economic interests of weaker sections along with people with disability. Now, coming to the schedules, 11th schedule and 12th schedule. Now, when we talk about schedules, they are added documents to the articles. And originally, India had 8 schedules, and now we have 12. So, in those added schedules, we have Article 243G and 243W, which talks about social welfare of inclusion of welfare and the welfare of the handicapped and mentally retarded people. Now, these terminologies will also phase out subsequently. 12th schedule says there should be safeguarding of the interest of the weaker sections of the society, including handicapped and mentally retarded. Now, we come down to National Sample Survey, and the NSS questions have changed much from 2001 to 2011 to document the presence of people with dysfunctions or disability in India. So the objective of the survey was to estimate indicators which will become standard throughout the survey. So inclusion of incidence and prevalence of disability, causes of disability, age of onset, and difficulties faced by persons with disability in accessing public funding and public building and transport have been included. Arrangement of regular care providers, out-of-pocket expenses relating to disability are worthy indicators used in National Sample Survey. Now, we have come a long way from collecting crude information on disability to specific disabilities. And there was a document released along with the policy document, that is the NS National Sample Survey, 76th round. We have in this 76th round change in the definition and difference in the definition of people with disability, difference in classification of disabilities, and difference in procedure adopted to identify disabilities. So when we talk about schemes, there are a variety of schemes exist to increase the skill and accessibility of healthcare to people with disability. We have Deen Dayal Disability Rehabilitation Scheme. We have assistance to disabled persons for purchase fitting of appliances. There is a fund for awareness generation and publicity for disability. Unique Disability ID project, which has been implemented in Meghalaya. There is augmentation of braille presses. There are DDRCs, and increase in number of DDRCs. There is another campaign which is Accessible India campaign or Sugamya Bharat Abhiyan. which is taking rounds. Research on disability related technology and products have got impetus in the last 5 years. There is an incentive scheme for providing employment to the private employers. Then there is inclusion of states panel injury center in every state where 5 beds will be free for people with spinal cord injury. Now, when we talk about skill and accessibility and access to funds, there is National Fund for People with Disability and there is National Handicap Finance Development Corporation, and there are awards for empowerment of people with disability for people with disabilities. So the rehabilitation measures which has been taken by the present policy document are not just physical rehabilitation, but they are also working towards economic and educational rehabilitation so that people with disability have dignified life in the society and they have increased vocational education. And we are also working on our policy document also suggests that we are working in development of rehabilitation professionals. Now, there is implementation of healthcare insurance. One is Niramaya Health Insurance Scheme. Another is Swavlamban Health Insurance Scheme. The coverage limit for Niramaya is 1 lakh and Swavlamban is 2 lakhs. And Niramaya can be accessed only by people with mental disabilities. And Swavlamban Health Insurance Scheme can be accessed by all people with disability, which are given in the Gazetted Notification of 2016. So the premium is for people who have family income of less than 15,000, they have to pay 250 rupees. And for Swavlamban Health Insurance Scheme, 3,100 is the premium, where 10% has to be paid from the pocket and rest will be refunded by the government. Coming on to the technology and the technological advancements, ICMR has come up with a document, NLEAP document, where they have set priorities on availability of certain devices. Although it's a good start, but then it is underutilized. The 21 assisted technology products have been there since long before 2016, but it's a commendable action from ICMR to generate this list. Now, the national centers, the premier institutes like IITs and AIMS, they have collaborated and they have dedicated Center for Assistive Health and Technology. And IIT Madras has been, in the forefront of development of assistive technology. IIT Madras and IIT Delhi. IIT Bombay has also started, and they have developed certain assistive technologies for handicapped. Now, these are examples of assistive technologies. One is IncluNav is for interior navigation or navigation within a building for people with dementia. Then you have Mavi for mobility assistant for visually impaired. You have reading assistant for visually impaired. You have got smart cane device for visually impaired. You have got onboard device. That's the name of the device, which tells you the bus number and the routes at the bus stations and at the designated bus stops. Then you have Tech Read, which converts the written documents, the printed documents into braille, and the person is able to read. Then you have certain good technological outcomes in the last 5 years. One is standing wheelchair, which is developed by TTK Healthcare at the IIT Madras. Then you have got outdoor mobility device, which is add-on mobility device, which converts manual wheelchair into electrical wheelchair. And there are some companies who are making frames, standing frame, sitting frame, and which can be used in different scenarios. Then you have installable swivel seat mechanism, where you can convert any car, any over-the-counter car which you get, and convert the seats into swivel seats without changing the basic structure of the car. Then you have mobile applications for the deaf. Then you have real-time braille converter, and then you have introduction of brain-computer interfaces or BCI devices. And people have been working on it since many years. And I think we will have our first EEG-controlled wheelchair in this year. Now, most of the institutions and most of the physiotherapy fraternity has shaped dysfunction into function, and we have been working with people with disabilities right from the starting. The job profiles and the extent of involvement in clinical areas is known. Most of the institutions highlight the teamwork approach, and it would be correct to say that physiotherapy is the strongest link in the chain of management of people with disabilities. And we have come a long way from impairment based management to shared goal setting by moving with the models. So we have, medical model where the healthcare professionals were the expert, and we have moved to political and relational models or ICF models where people with disability and healthcare professionals, especially physiotherapists, are making shared goals and have shared goal setting. Now, role of PT as such, we have got different specialties, and when we talk about role of physiotherapy, there is no SOP or documentation on evidence of roles of physiotherapy. It will be better to identify role in terms of lead role, adjunct role, or supportive role, and we are working on types of functions, that is physical function, cognitive function, and social function. So, depending on the impairment, depending on the health condition, depending on the scenario, whichever is dealt by us in the lead role, that becomes our role. That is, if you look at this dysfunction in physiotherapist role matrix, you see that we are leading role. We are leading healthcare provider in physical function and cognitive function, but we are adjunct and supportive, providing adjunct and supportive role in social functions. So now when we talk about social function and when we map out our roles with CBR matrix, there is the last domain of self-help group advocacy, and there we are providing supportive functions by being a moderator, or depending on the situation or depending on the roles we are providing in CBR matrix, we become lead provider or adjunct provider or supportive provider. So I would say we have started mapping the roles of physiotherapist in CBR matrix, not necessary community-based rehabilitation matrix, meaning community-based rehabilitation physiotherapist. But if you look at the health domain, the education, the livelihood, the social domain, and empowerment, everywhere the physiotherapy has lead and adjunct roles to provide, especially the health, early education, and livelihood training, that is vocational rehabilitation, doing task analysis and doing vocational rehabilitation, providing recreation and leisure. We have been in forefront for improving physical functions. And when we talk about empowerment, advocacy, self-help group, and community mobilization, we are in adjunct and supportive group. So I think that would be a better way of delineating physiotherapy roles in the lives of people with disability if you map out your functions along with CBR metrics. Now we have started to take a humongous task to map physiotherapy roles through documentation, through research work, through the number of projects held, etc. Now we come to the ways we achieve more capability to deal with disability. Now we have answered two questions. We have answered, how we created the framework for people with disability, how we have contributed for people with disability. Now we can talk more of how we can improve our capabilities to handle disabling situations. Physiotherapists have been, in research in the last decade. There are a number of, research studies coming out from India and, Indian researchers who are in the Western universities or who are in foreign universities, and it becomes little difficult to gather data from PubMed, depending on the kind of role or the physiotherapists play in lives of people with disability. But I have known personally that there are many projects held by various physiotherapy departments around the country, and these projects are funded by national funding agencies and international funding agencies. Then there are a number of institutions which are imparting PhDs. The government institution, they are less. The higher education institutes, they are less in number, who are providing opportunities to physiotherapists because the physiotherapists do not meet the eligibility criteria. Now, if we look at the Vidwan profile, which is created by Ministry of Education and Human Resources, you can identify that there are 465 people who have registered in the field of physiotherapy, academics and research, and there are 261 people working with rehabilitation, and there are many deactivated profiles, including mine. So, if you collate the whole list of people working for disability, that's huge, but we often do not hear about them. Then there is increase in number of workshops and conferences conducted in the last year, and this is what we need to bother about the research. When we talk about higher education, we have got masters and PhD, a lot more masters and PhDs which are coming out, but there are certain damaging trends because there are substandard PhD being imparted. Government institutions have been left far behind because sometimes we do not fulfill the eligibility criteria to enter the streams which would help in widening the scope of physiotherapy or increase knowledge. We are all consuming derived knowledge, but we have never come in the forefront to get first hand data, and there are a handful of physiotherapists who have postdoc and collaborations, and but they are handful. There is need of multidisciplinary education and horizontal growth, which would be achieved by National Education Policy 2020. I would suggest that we should shed this understanding that physiotherapy can only progress by delving into the fields of physiotherapy. If you know a little bit of technology, and if you pour into the field of technology and you go to the depth, I think it will be beneficial for the growth of rehabilitation in whole. Then we talk about practice and entrepreneurship. There are many physiotherapists who are entrepreneurs, but there is no credible source of information on the practice. It's more of information coming out of newspapers, the magazines. There are many physiotherapists who have made mark in sports sciences, and that is evident because we have been seeing how many sports associations have been, giving role to physiotherapists. There are many Paralympic there are many organizations who are training Paralympic athletes, and they have employed physiotherapists. So there is there's a broader need to include people with disability into our curriculum, and there's a need for physiotherapists to be present at vocational rehabilitation too. We should be present at special education. We should be present at return to work and ergonomics, because finally we would be able to make a person with disability into a contributing member of the society. Now, when we talk about disability, we answer the questions: what we have done for people with disability, what we are doing with for people with disability, how can we increase the standards. But one thing we should care about is, how do you view disability? There are many definitions of disability. There are 100 plus definitions of disability. There are 100 plus situations where philosophical situations where you have tried to explain disabling status. So when you look at all these disabling situations, we need to acquire multiple views of disability, and we should know where we can interfere and stop the disabling process. And when we know about the disabling and enabling situations effectively, we would be able to handle surveillance in disability better. We would be able to take public health stance in disability better. Now, when we talk about models or the views of disability, we need to look for superiority of view, both in vision and action for disability. And we have moved from single models to pluralistic models, from single medical model, social model, charity based model, to more potent international classification of functioning disability and health model. We have also got Quebec ICIDH developed disability creation process model. And disability creation process model is a little different from ICF model, though ICF model has been in the forefront since 2001 in national sample survey and in understanding disability and in our curriculum. But there is a difference in how we deal with personal factors in ICF and how the social participation is termed in the disability creation process model. So we have got these two models for disability and activity limitation, and we need to understand difference between these two models and similarities between these two models. Now, when we talk about ICF model of viewing disability, it's a combination of medical model and social model. You can call it biopsychosocial model, and disability creation process, on the other hand, is developed on the development model or the anthropological model of human development, and it only talks about social participation. Um, that is, what is necessary for living or survive in this world. Then there is difference in the definition of the participation in ICF and disability creation process model. Here in ICF, the participation is interaction between individuals, health condition, and contextual factor. But in DCP, the intrinsic individual factor or the capability of the individual interacts with the extrinsic environmental factor. So when we talk about the ability of the person, we talk in terms of capacity in ICF, and we talk about capability in disability creation process model. Then we come to the environmental factors in ICF. The influence of environment is not clearly identified conceptually, but in disability creation process model, social participation itself is incorporated as a determinant of, or the output of the environment. So when we look at disability creation process, it gives you three layer information. One is the satisfaction which a disabled person has in performing those activities in life. To what is the kind of assistance the person is taking, whether the activity which is being put into question is practiced by the person or not, or it is accomplished by proxy. So there is a difference in the process, how you come out with the definition of participation in ICF and in disability creation process model. Now, we also need a model to identify ways to intervene rather than working with hypothetical frameworks and manage the impairment. I would give example of low back pain. We have been studying low back pain, impairment-based treatments. We have been working on how to limit low back pain using different techniques, different management. But then finally, we have ended up with treatment-based classification. So we have forgotten about the impairment. We are working towards activity limitation and participation restriction. So we need to have a little bit broader outlook, and we need to think of disability in terms of public health. Now, public health is concerned only with communicable disorders, certain non-communicable disorders, and the general problems which are associated with communicable diseases. But when you talk about disability, disability does not equate to illness. It will never be reduced. It will always be there, and environment is a crucial factor, both enabling and disabling environment in health and well-being of people with disabilities. That should be understandable, and it should be incorporated in public health. Then people with disabilities, like any population, they should also be involved in decision-making process when public health is concerned. Because if you look at public health, it's handled by a group of eminent scientists, eminent administrators, and depending on the threats perceived, they are taking the action. But when you talk about disability and public health, I think it would be necessary for disabled people organization to step in and aid public health professionals. Then we have increased and decreased opportunities for people with disabilities affecting participation in societal activities. Now, public health cannot deal with participation in society. Public health cannot deal with environmental barriers, but it should be there in the framework where you regard environmental barriers as facilitating, meaning environment as a facilitator or enabler in any of the surveillance undertaken by the public health, domains. Assistive technology needs to be a part of public health, and physiotherapy has got a role to play in adoption of these assistive technologies. Now, physiotherapy and public health approach have to go hand in hand. And the objectives should be to increase access of assisted devices and technology, increase in access to health and wellness programs, reducing environmental barriers, and we have to prevent transformation of primary impairments to secondary impairments. Now, primary impairments and secondary impairments have been defined by March in 1999 by the Institute of Medicine. And this transformation of primary disability, primary impairment to secondary states and deterioration of further mobilities should be taken into the picture in public health intervention. We should also remember that there are diseases which will never recover, the person will never recover. Secondary conditions will always happen, but how to stop them should be kept in mind. And then, there are primary impairments which affect children differently, which there are situations which affect adolescents and adults differently. Now we have to focus more on prevention of transformation of primary impairments to secondary impairments. So finally, we have got skills for health improvement, health protection, and improving services, and we can be a part of a larger, public health. We can be, forefront. We can be at forefront, or we can have a physiotherapy role in public health in prevention of disabilities. Now we come on to the topic of public health surveillance. Public health and disabling states are incomplete if you do not have surveillance in the picture. So when you talk about surveillance, it's an ongoing collection of data, interpretation of health data, which is essential for public health, and it's closely integrated with timely dissemination of information for intervention. So we should understand that surveillance systems are not equivalent to data systems or surveys or routine records, but surveillance is ongoing and it is linked with intervention. So these are the two states where physiotherapy needs to be in the forefront if we want to make people with disability realize their rights, or they should be actually able to enjoy their rights. Now, the uses of surveillance can be to monitor current status, document trends, change over time. We can have snapshot status, how the disability in particular health condition is doing. And we can also have our surveillance system evaluate interventions. You must have heard about CBR program, management of CBR program, indicators of CBR program, how you can evaluate a CBR program, etc., etc. So if we utilize these surveillance systems to evaluate interventions, probably we can, increase our presence in public health systems. Now, there is deficiency in public health systems as far as rehabilitation is concerned, or whether it is communicable disorder, whether it is non-communicable disorder. There are two indexes which have done fairly well in economies. One is index, one is automated decision system making. So when we talk about index, these are composite indices which are telling you about your heart health or nutritional status, or your physical activity profile, etc., which you have from your wearable devices, and that can be compared across geography and over time. And we can have some indexes about physical function in people with disability coming up. Then you have automated decision making, which is absent in our public health systems. Uh, there is no warning level or cutoff. We need a cutoff level or a warning level to be established in disability, and we should start the intervention as soon as the cutoff level is reached. So the example which I can give is, if a child with cerebral palsy or adult with cerebral palsy is coming to CP clinic, for a long time, and the person misses the timely visits for at least one or two, meaning at least two visits, then the system should dispatch the workers to locate that person, so that we can continuously track or monitor the disabling status of a person, and we can get to the root of the problem. So the message is, we need a supportive health policy to reinforce surveillance. And we should bring public health and physiotherapy at all stages of rehabilitation in the forefront. So this is the message. And the picture says that we should not be following Western concepts of health, disability, and independent living. They are not entirely translatable to India, and we cannot think of independent living. Although at our background, we can think of rehabilitating a person with disability to have independent living status, but that will never happen. We would be trying to raise the capacity and capability so that the performance of people with disability, the elderly, and the weaker sections improve. So we now strategize priorities in disability. So the first priority is we need to know the pathways of disability. We need to know surveillance. We need to get caregivers on board and make them the active members in surveillance team. We need to have registries based on disabling states, and we need to prepare for inclusion based on these strategies. Now, for developing model, we have moved from medical model, social model to ICF to disability creation process, but we need our own models, a country-specific model. So those models are not, we are not coming up with new ICF or new models. What I'm talking about is develop a surveillance model for each of the disabling states. If you talk about children with cerebral palsy, we were able to develop a model for ambulatory children and for non-ambulatory children. So what we do is we review the knowledge what exists and what we see in the society. Then we document the phenomena. We try to see how the body structure is changing, how the body function is changing, and we combine this information with the epidemiology of limitations. So this is something which we should always think of. What is the epidemiology of deteriorating state of mobility in children with cerebral palsy or in adults with cerebral palsy? So we have got a course, we have got certain courses provided by the ICF. We can utilize them to document the limitations. We can also document at risk of developing secondary disabilities. We can document body structure and body function categories. So if I want to give you an example, I sampled or our team sampled cerebral palsies from 18 states through 5 cultural zones: east, west, north, south, and central India. And we documented body structure, function, and activity limitation. And I included developmental creation, disability creation process model to document social participation. And then we did structural equation modeling to come up with pathways, various pathways, where finally the quality of life of adults and adults with cerebral palsy is being affected. So we have the inputs of body structure and function, we have inputs of activity limitation, and we have inputs of participation restriction, and finally we are able to find what is the influence of each of this domain in ICF and DCP affecting the whole quality of life. So when we talk about ambulatory models of cerebral palsy, we have got gait pattern, we have got oxygen and consumption, you have got flexibility, and you have got body alignment states which are coming into the picture. And these there are direct and indirect pathways of influence on pediatric quality of life or quality of life in adults and adults with cerebral palsy. So these are the two models. So, this is just an example where my model is predicting participation and quality of life with this much percent. So I assume my model is, fit. It's a good fit for having a surveillance on adults and adults with cerebral palsy. So these are some of the outcomes of how there is direct and indirect influence on, participation through individual indicators of physical function. Next, we should talk about is data sharing. We do not have data sharing policies. The government does not have information about registered people with disabilities and NGOs because the data is not, something which is uniform. The data is not collected on terms of body structure and function impairments or activity limitation, where we can use the data for surveillance. So, if I give an example, there is ICMR funded project on developing standards, which was headed by Dr. Kavita Raja. So they had come up with Sakshama card, which has got all the inputs of body structure, function, activity limitation from variety of professionals, and that can be used for surveillance in NGOs. It can be used for surveillance in private clinics. It can be used by the government machinery. So at the end, we want a uniform system of documentation which actually helps prioritize our management proactively. Then I talk about assistive technology. We have already looked at assistive technology. We should not only bother about the technologies for mobility, but also for each domain of participation. We should be able to cater with our assistive technology. And assistive technology development is everyone's responsibility. If you have interest, you should have credentials in assistive technology, and it will improve your depth of knowledge for improving somebody's disabling state. Then we come down to the core of surveillance, public health, documentation, framework, everything. We are working in a framework, and finally at the end we are able to create instruction manual. This instruction manual is akin to a statistical analysis plan which you embark in your research work. So let's name it as life care planning. So life care planning is kind of a instruction manual for certain people with disability, which is centered around their activity, and it helps them facilitate daily living activities in their health, chronic health condition or disability. So life care planning is a document that describes information for provision of appropriate services and support, and it must be updated regularly to capture any changes in situation of the person with disability. It should be easy to use, culturally appropriate, and it should be legally sound. So here is one of the frameworks you see in life care document. So you look at prevention, you look at follow-up, remediation, rehabilitation, support, respite, institutionalization, vocational rehabilitation, novel employment opportunities which have been generated, which should be included in your life care plan. The data is everywhere, but it cannot be utilized because it is not standard. We do not have SOPs. We do not have any surveillance state. We do not have registries, and we physiotherapists cannot access registries because there is no framework, national framework, government framework where you are registered to a government body. The Ministry of Family Health and Welfare has started uh, a registration of health professionals, private practitioners, for midwives, nurses, and physicians, but it is not there for physiotherapists. So um, if you think in terms of Rights of People with Disability Act, our act is not influencing the government machineries to include physiotherapists, to help physiotherapists help people with disability. So, in short, although we have got Rights of People with Disability Act, but restriction of healthcare professionals from registering in a central database, it is something which will hamper people achieving rights, practicing their rights. We have to recognize phenotypes of people with disability, whether it's cerebral palsy, whether it's TBI, whether it's stroke, because we cannot give the same intervention to everyone. We should recognize the phenotypes of caregiver. We should recognize phenotypes of disabling states, and we should not just stick to run-of-mill interventions. We should think in all the directions for providing help to people with disabilities. Coming to policy implications, I have got only two. We should have sustainable surveillance program to monitor indicators of physical functioning, social functioning, and cognitive functioning. We should have national registry both for people with disability and people with elderlies. So my take home message is, surveillance. We should always think in terms of prevention, surveillance, and we should always monitor that primary impairment does not become secondary impairment, and it does not become what you say uh, cause deterioration of mobility states and restriction of participation. So that's all for from me. Thank you very much.